Good morning, everyone, and welcome to Citywide Medical Grand Rounds this week. Today is Thursday, October 19th. I'm Dr. Madeline Verhovsek, Chief of Medicine at St. Joe's. Next slide, please. And delighted for today to be hosting on behalf of St. Joseph Healthcare Hamilton. Next slide, please. So we'll start with a land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in a spirit of peace, friendship, and respect. Next slide, please. Really pleased to welcome our three presenters today. They have been working hard on this presentation on the topic of decision-making for end-of-life care, withholding resuscitative measures in 2023. Our presenters are Sabrina Yeung, Jasper Ho, and Suraj Gopinathibirla. And we have their supervisor, Dr. Harun Yusuf, who is also here and helping me with co-hosting duties. So I'm going to hand things over to Dr. Yusuf to provide a bit more detailed introduction to our three presenters. Here you go, Harun.
Awesome. All right, thanks, Dr. Verhovsek. So I applaud these three residents for taking on this challenging topic. They'll be getting into some of the CPSO policy changes regarding withholding resuscitation measures. So we have Dr. Suraj Gopinathibirla. He's a PGY3 internal medicine resident interested in allergy, immunology, and GIM, and he did his medical school at McMaster University. We have Dr. Sabrina Yeung. She's a PGY3 internal medicine resident interested in infectious diseases, and she did her medical school at the University of Toronto. And then finally, we have Dr. Jasper Ho. He's a PGY3 internal medicine resident interested in critical care and general internal medicine. And he does medical school at McMaster University. And in his spare time, he likes long walks on the beach and doing central lines. So I'll hand it over to them.
Perfect. Thank you, Dr. Yusuf and Dr. Verhovsek for the introduction. And we're excited to be giving this talk. So as we talked about, the title of our talk is Decision-Making for End-of-Life Care, Withholding Resuscitative Measures in 2023. Next slide. With respect to objectives of our talk, I think we want to understand the legal, ethical, and professional obligations regarding the withholding of resuscitative measures in adult populations, and to explore and understand the outcomes and predictors and mortality in hospital cardiac arrest and resuscitation. And finally, we want to explore patient-physician understanding of resuscitative measures and outcomes. Next slide. Conflicts of interest. We don't have any conflicts of interest to disclose. So moving on. So with respect to the outline of our talk, I think first we'll review the general terminology to get everyone up to speed on the same page, and then enter a clinical case in which we can review the CPSO policies and also at a more local level examine the Hamilton Health Sciences and St. Joseph's Hospital policies surrounding end-of-life care. And then we'll be able to apply our ethical framework to the case and to the question at hand. And finally, we move towards examining survival outcomes and predictors of mortality following resuscitation. To begin our talk, we'll review some common terminology. Next slide. In this, we want to quickly cover a few things. The first being advanced care planning. So basically, advanced care planning are conversations to help identify the patient's personal, cultural, religious/spiritual values and beliefs, as well as their wishes, including which treatments they may or may not want at the end of life. The aim of advanced care planning is to prepare patients and substitute decision makers for future decision making, whereas goals of care discussions are conversations that are taking place in the context of a significant illness or disease, where decisions around treatment and general care need to be made in the foreseeable future. And it's important that we differentiate advanced care planning and goals of care planning from consent itself, as consent is something that must be obtained prior to any proposed treatment or direction of care. And it's been shown that timely end-of-life discussions can lessen family distress, ensure care is aligned with patient values and beliefs, lead to improved patient outcomes, quality of life, and also decrease overly aggressive or potentially harmful interventions. Next slide. The next question might be, what are resuscitative measures? So the CPSO defines resuscitative measures as medical interventions that may be provided following cardiac or respiratory arrest in an attempt to restore or maintain cardiac, pulmonary, and circulatory function. And here, things such as chest compressions, artificial ventilation, intubation, and defibrillation would fall under the resuscitative measures as defined by CPSO. However, things like oxygen suction, intravenous medications, and vasopressors would not. Next slide. Another concept intertwined with the concept of withholding CPR and withholding resuscitative measures is a notion of medical futility. So medical futility is as old as medicine itself, but has no universal definition. Even looking back to the works of Plato, notions around like a life with preoccupation with illness and neglect of work is not worth living. So we have these definitions popping up in documents long ago. Next slide. So medical futility, unfortunately, doesn't have a universal definition, whereas some guidelines have narrowed it down, such as the ATS guideline 2015, to futility being used only under rare circumstances that an intervention simply cannot accomplish the intended physiologic goal. But in literature, we see more broader definitions of medical futility being proposed, like this one by Schneiderman in 2011 that notes that medical futility has both quantitative and qualitative component. Next slide. The Canadian courts. The definition often used derives from the Special Senate Committee on Euthanasia and Assisted Suicide from '96, in which futile treatment is defined as treatment that, in the opinion of the healthcare team, will be completely ineffective. This term does not include treatment that may be effective, but whose results are deemed undesirable. And this narrowing of the concept of medical futility for the Canadian courts is done in an attempt to emphasize that the potential dangers and problems underlying the concept of medical futility, that if interpreted broadly and used to justify withholding of treatment, can be for socioeconomic or value-related reasons, is detrimental. Next slide. So we'll move towards a clinical case.
Thank you, Suraj. So we'll go over a little bit of a lengthy case, but I think this case really highlights what we're trying to talk about today and the questions that arise from taking care of patients who may be critically ill, or the question of whether they deserve resuscitative measures comes up. So next slide, please. So we'll begin with the general background of the patient. We'll call him Mr. D. He's an 88-year-old man admitted to the inpatient medicine ward. He comes to the hospital with severe, very severe bilateral gangrene secondary to peripheral arterial disease, and he's very delirious on admission. Unfortunately, he's also described as moribund or appearing or close to death. Cachectic, and he's drowsy as well and not able to make decisions for himself. He does have a listed previous medical history of type 2 diabetes, atrial fibrillation, stroke, known ischemic cardiomyopathy, end-stage kidney disease on hemodialysis, the peripheral arterial disease, as well as COPD. Slide, please. Unfortunately, prior to this admission, he had been declining over the last 2 or 3 months with multiple hospital admissions and had recently been transferred to a long-term care facility at a family meeting and at the LTC, he stated that he wished to be full code at that point in time. However, once again, on this admission, he is too delirious. And so his daughter, who is a registered nurse, is his substitute decision maker. The staff physician assessed the patient shortly after admission, had a very long discussion with his daughter, communicating that he was almost certain that her father was going to pass away. And he was very worried about his state of health. It was understood at the end of this conversation that the patient will be, quote, full code. Next slide. The patient was treated conservatively with antibiotics for 1 or 2 days and symptomatically improved and perked up and was eating some of his meals, however, had excruciating pain in both of his lower limbs. And so because of his improved status, ultimately a bilateral transfemoral or above knee amputation was recommended for palliative intent, not curative intent. He underwent successful surgery and was admitted to the ICU given his comorbidities for post-operative monitoring. He made it to the ward successfully, and post-ICU discharge day 1, it was noted that his left leg stump was already dusky and gangrenous. The patient slipped into a mixed delirium over the next day. He became mottled, not arousable to sort of stimulation, and he was not able to clear his secretions, prompting sort of decompensation into frank respiratory distress. Next slide. The 2 staff physicians involved in this care, so the critical care outreach team physician and the staff GIM physician, assessed him independently on that day and determined in their clinical expertise that resuscitative measures, as we previously discussed, and in this case, including bringing the patient back to the ICU, would bring Mr. D more harm than benefit. And they specifically worried about things such as chest compressions, given his sort of risk factors for osteoporosis, the fact that he was on full dose anticoagulation, the fact that he had already had an ICU stay and had a severely decreased functional status. They signed a no CPR order, put it in the chart, and it was made active, and called the SDM, but she wasn't around. So they left a voicemail asking her to call them back. She called the ward back, but didn't reach the physicians. And so she came to the hospital where she found her father in respiratory failure on the brink of cardiopulmonary arrest. She insists on full resuscitation. The critical care outreach physician arrives, explains his rationale, withdraws, withholds resuscitation, and the patient very traumatically dies in the presence of his daughter. This case rings a lot of bells for a lot of us in the general medicine world or the critical care world. We see these comorbidities all the time, and we see patients who have similar clinical courses. But we're going to use this case to explore the question, if we were in the same situation, what would our legal, professional, and ethical obligations be to the patient and maybe even the family? Next slide. So we'll start with the legal obligations. Caveat that I am not a lawyer and I will never be a lawyer. This was a real case, as you may have guessed, where Risnack versus Livingstone. It occurred in a major Ontario teaching hospital in 2008. And after the sort of conclusion of the events of this case, the daughter, the SDM, brought a medical malpractice suit against the 2 physicians, the internist and the intensivist. And this case centered around 2 questions, both around the standard of care. Number 1, was the standard of care breached when the 2 physicians wrote a DNR order, when there's already an active full code care of plan in place without obtaining consent from the patient or SDM, and were they within their rights to change that care of plan as per the definitions of treatment in the Healthcare Consent Act? And number 2, were they in breach of the standard of care by failing to communicate the proposed changes to the plan to his code status in a timely and preemptive manner to the daughter? On both accounts, next slide, the court found that sort of the 2 physicians were not in breach of the standard of care, and we'll briefly go over the reasons why. For the first one, the court found that the act of writing and signing a DNR order, even in the face of an active full code order, does not constitute treatment within its meaning in the Healthcare Consent Act. The treatment here that is proposed is CPR and resuscitation, and hence admission to the intensive care unit. And a DNR order actually precludes its automatic initiation in the event of cardiac or cardiopulmonary arrest. Therefore, the court felt that consent was not required in this circumstance. And they heavily cited the Rasuli case from 2013 at the same hospital, in which treatment decisions were clarified as having to be specifically proposed. And we can chat a little bit about that later. For the second point, the courts felt that the physicians made reasonable attempts to communicate the proposed changes. They called the SDM before the patient was in frank cardiopulmonary failure. And they were held justified in citing this order before full communication was had or consent was had, because their fiduciary duty was only to the patient and not to the SDM. In hindsight, they could have improved their communication, but they were not blessed with that gift. Next slide. We'll move on to professional obligations. So at the time of the case, the CPSO policy was actually quite lenient in that the two physicians were in line with CPSO policy at that time in both writing that order and not requiring consent or consensus before they wrote it. The changes over the next decade and a half were heavily influenced by the Resuscitative case, next slide, in 2013. Which ultimately, as we talked about, determined that the meaning of treatment requires something that needs to be proposed specifically, and that also withdrawal of life-sustaining therapies requires consent, but not necessarily withholding. In 2015, the CPSO policy was amended in the wake of the Resuscitative decision to actually require consensus before this order was put in across the province. And in the interim, before, if there's still conflict going on, interim CPR was actually mandated as the standard of care. So that's a very interesting shift in perspective and policy. The next year, the policy loosened a little bit, still requiring consent, but adding a caveat that unless the physiologic goals of CPR were achieved, then CPR had to be continued. So our interpretation of that would be return to spontaneous circulation and not necessarily a good functional or neurologic outcome. In 2019, there was sort of another change in the CPSO policy, once again leaving the requirement for consensus before the order was put in. But physicians are now prescribed to the standard of care, which may or may not include CPR, and there's a lot of room for interpretation there. Next slide. In the wake of the 2019 decision on the case that we talked about, the CPSO policy was updated this March, putting it in line with the court's decision in that physicians don't need to obtain or require consent to withhold resuscitative measures, and that they are able to write this order in the chart when they feel it is medically necessary. There is the important sort of recommendation and a policy that we still need to communicate well with families and their substitute decision makers at the earliest possible convenience, offer routes for mediation and communication and conflict resolution as needed. But certainly now the court and the CPSO policies are congruent. Next slide. We'll briefly close this chapter with a look at our local policies that actually inform our practices in our hospitals and whether we are supported by that. And the conclusion here that we can draw is both our hospital systems in Hamilton need updating of these policies, and certainly policy updates are underway. So at St. Joe's, once again, physicians are not allowed to write the DNR order when conflict resolution is underway, but we are allowed to follow the standard of care in the meantime. Whether or not that includes CPR is up to your interpretation. Next slide. Similarly, at Hamilton Health Sciences, it's the same thing about writing the order without consensus and whether CPR is indicated or not. There's a bit of interpretation. Slide. We'll close off the section for real this time with a look at, now that we've looked at the legal, the professional obligations, we'll examine this case and these decisions through a very basic bioethics ethical framework, looking at autonomy, beneficence, non-maleficence, and justice. Next slide.
In looking at autonomy as it pertains to the decision to withhold resuscitative measures, autonomy has both positive and negative aspects. With respect to negative aspects are the rights of the patient to decline or refuse proposed treatments, And then here you'd have to respect the patient's previous advanced care planning goals of care discussions. When it comes to the negative aspects of autonomy, where it comes to positive aspects of autonomy in which patients seek out and ask for certain medical interventions, it should be noted that evidence-informed medical opinion is necessary to constrain the options available to patients to ensure that they receive ethically appropriate care that's supported by the best available medical evidence. This is to say that patients' positive autonomy does have limits, and those limits are under the guidance of a medical professional and the evidence that they have available in proposing interventions. So this prevents patient requests for potentially inappropriate medical interventions for their clinical situation. Next slide.
When we propose or withhold treatments, we must think about what good we're doing and what harm we may be preventing or from doing. And these are the concepts of beneficence and non-maleficence, or first do no harm. And these are very, of course, individualized sort of considerations for the patient and the clinical context, and also who is providing these. In general, the goals of medicine could be said to, we are trying to preserve life, restore health, relieve suffering, and restore and maintain function. And certainly in the event of cardiopulmonary arrest, we are trying to do all of these things if possible. And that's the good that we're trying to achieve. But it's important to think about, are we realistically going to achieve these expected benefits with resuscitation? And we'll talk a little bit later in this hour about whether we are even able to do that with our, even with our expertise and what we know about patients in these situations. We have to think about the possible harms of resuscitation as well. And we know that patients undergoing resuscitation can have any number of sort of significant morbidities afterwards, extended suffering, decreased quality of life, decreased neurologic status afterwards. Many patients post-arrest have post-arrest brain injury or hypoxic ischemic encephalopathy that leads to death and morbidity. And in the case of, for example, things like penetrating traumatic cardiac arrest, where we know the rate to return of good neurologic function is in the very low single digits, is putting someone through aggressive resuscitation. Is that worth it on the balance of things? So it's a very complex and individualized consideration. Next slide.
In looking at justice as it pertains to our clinical conundrum, justice requires the balancing of individual needs and requirements with societal limitations. And a study out of the US showed that in the years 2011 to 2012, the inflation-adjusted cost of post-cardiac arrest care in the US was noted to be $11.1 billion. And in our publicly funded healthcare system, it brings up the question of resource allocation in the face of scarcity. However, on the other side, it's also important to ensure that there is equitable access to resuscitative measures for patients that are selected and thought to be good candidates, and not to allow our personal biases to mark our decision-making process and to evaluate the evidence around prognostic factors around resuscitative measures and the outcomes carefully, which we'll go on to explore later in our talk. And it should be important to note that the concept of justice as it pertains to this clinical conundrum is actually not explicitly examined in the courts itself. And when it comes to justice, there's no universal method that's agreed upon that allows us to interpret utility in a meaningful way to mark policy. There have been attempts made at this, for example, including quality-adjusted life here in the formula, figuring out medical interventions and their effects. But at this moment, it's difficult to capture this notion of utility effectively in our policy and clinical decision-making. Next slide. So we talked about the professional obligations and ethical and also legislative obligations per the court case. Looking pragmatically at what physicians can actually do with the policies, we found is that physicians need more than just policies and legislation to inform their clinical care. So this is actually an older paper from '96, which examined physicians from a hospital in San Francisco. And at the time, the American Medical Association policy and also the San Francisco hospital policy were aligned in the fact that physicians can write DNR orders or no CPR orders for patients without having that discussion. And here, where they interviewed, they found that a significant portion of physicians still believe that CPR should be offered regardless of the benefit. That was 52%. Of that 52%, there was a portion of them that were not aware of the hospital policy. But for the 58% that were aware of the hospital policy but still offered CPR regardless of the benefit, there was a host of factors that were discussed that could explain this discrepancy. One being the risk of medical legal action. Two, there was this notion of regardless of benefit, that if they offered CPR to patients or decision making, that patients would say, no, I don't want it. So those are some of the factors that could explain the discrepancy between physicians offering CPR when it was thought to be not beneficial for patients at this institution. Next slide.
So next we're going to be switching gears and chatting a bit about patient predictors following cardiopulmonary resuscitation and outcomes of resuscitation. To make sure we're all on the same page, we're going to be discussing in-hospital cardiac arrest, not out-of-hospital cardiac arrest. We're going to be focusing on the topic of resuscitation and not withdrawal of life support, which is a whole topic within itself. And then also making sure we know we're all talking about adult patients. So in general, adult in-hospital cardiac arrests are a challenging topic to study. Much of our research that we have in literature focuses on out-of-hospital cardiac arrest. So sometimes the data is extrapolated or in-hospital. The majority of the studies that we have are observational. To our knowledge, we couldn't find any randomized control trials really surrounding this topic. And with these observational studies, they're going to be subjected to biases. And overall, all the studies are quite heterogeneous, incorporating a number of patients that are quite different and from different centers in different countries. However, it's still important to study this topic as the estimated incidence of in-hospital cardiac arrest, it occurs in about 1 to 6 events per 1,000 admissions. So as physicians, we are challenged with having these goals of care conversations with our patients and discussing the issue of resuscitation, usually when a patient is admitted to hospital. And that incorporates us, or requires us to incorporate a number of patient factors to have meaningful and fruitful discussions with patients, and usually give a at times give a recommendation to a patient about whether we would recommend resuscitation. So that can include things such as considering the patient's comorbidities, their functional status, their goals, their wishes, and what we predict would be their survival outcomes and what their quality of life would look like after. And this could a reason why this topic can be challenging to discuss with patients is that patients overall don't necessarily have a very good understanding of what resuscitation means and what that entails for them and looks like for them in the moment and in the future. And a part of this could be due to studies have shown that the media has grossly overestimated a patient's probability that they would survive resuscitative measures in hospital. And studies have actually gone to show that they depict higher rates of survival. So knowing this, what do we discuss with our patients and let them know based off what the literature says? So studies will look at various numbers of outcomes. Many of them will look at survival as a potential outcome, and that could include short-term survival. So the shortest would be sustained ROSC following resuscitation, so that they're able to transfer to ICU. Survival to ICU discharge is another outcome. Then further along, survival to hospital discharge or 30-day survival, and a bit long-term would be more along the lines of 1-year survival. And then many patients will find that it's important to also discuss their predicted quality of life or functional measures or neurologic measures following resuscitation. So there have been a number of studies that have looked at things like neurologic function with the cerebral performance category, the patient's GCS, the location of where they're discharged after hospital, so that's back to home or to long-term care or more assisted living, quality of life, adjusted life measures like EQ5D, and their ability to perform ADLs following resuscitation. For the purposes of this talk, we're going to focus mainly on survival to hospital discharge, 1-year survival, and a functional measure following cardiac arrest. So the first study we found, or we want to look at in more depth, is a meta-analysis that looked at the patient's 1-year survival rate following in-hospital cardiac arrest. And this is a study that came out in 2018. It included 39 studies all the way from 1985 to 2015. The patients that they captured were 54 to 86 years old, and it included about 1,350,000 patients. And what they found overall was that the survival outcomes are suboptimal. So the 1-year survival rate was estimated to be about 13%. And then the survival to hospital discharge was about 17%, meaning that if you are to survive until hospital discharge, it's likely that you'll survive until you will be alive at the 1-year mark. Overall, as you can see from the markers or the test heterogeneity, the studies are quite heterogeneous. And a potential reason for that is that when they looked at just subgroup analysis to see the differences of survival between cardiac and non-cardiac patients. So cardiac patients would be patients who are admitted primarily for a cardiac issue or cardiac surgery issue, or admitted to a cardiothoracic ward. They found that these patients had a much higher rate or survival to hospital discharge and 1-year survival. So their survival to hospital discharge was about 50%. And that's mainly because we know that patients who are admitted for cardiac causes, or these cardiac patients, typically have a shockable rhythm when they undergo cardiac arrest. And we know that that is a rhythm that is associated with a higher rate of survival. And overall, what we found from looking at the literature as a whole, and not just this study, was that most studies report a survival to hospital discharge that is less than 20%. But what's also important to note is that these numbers, so less than 20%, so 1-year survival being 13%, these are study population numbers and should be really used cautiously when applying them to a patient on a patient per patient basis. So that number might not apply to the actual patient that you are speaking to, and they should be looked at on an individual basis. The next study that we found was a systematic review that focused on quality of life and functional measures. So the main functional measure that what they found was studied across the literature was the topic of cerebral performance category, the cerebral performance category scale. So what this is a scale that's applied to patients post-cardiac arrest. A CPC score of 1 would be the best, and 5 would be the worst, or 5 would be the worst. And generally, a CPC score of 1 or 2 is considered to be a good neurologic outcome, while anything higher is considered to be poor. So they were able to find 15 studies that looked at a patient's CPC score before and after resuscitation and compared this. And what they found was that the risk of being alive following cardiopulmonary arrest with resuscitation and being alive after this, they found that there were 6 studies that showed an increased risk of having a CPC score greater than 2, so a poor neurologic outcome. 2 showed a small decrease in risk, and then while one study showed no change. And what they found overall was that for patients who actually survived until hospital discharge, the proportion of patients that had a CPC score of 1 or 2, so a good neurologic outcome, was anywhere between 33 to 89%. However, when we looked at patients that underwent resuscitation and whether they survived the resuscitation or not, that number becomes much lower. And the proportion of patients that have a CPC score or a good neurologic outcome becomes about 5 to 24%. So there's quite a large variation in these estimates, but shows that if you actually undergo resuscitation and survive until discharge, there is a higher chance that you will actually be discharged with a good neurologic outcome. So next, we wanted to find what factors are associated with worse mortality following resuscitation, or for patients that are going to be resuscitated. So there's a number of studies that have looked at factors pre-arrest, so factors that patients would know when they're having a discussion with the patient before they actually decompensate and get worse. And these factors would be important to take into consideration for individual patients if they have, especially if they have multiple kind of negative prognostic indicators. So these include, there's been evolving research that shows increasing or worsening frailty is associated with worse mortality, male sex, increasing age, sepsis, active malignancy, and renal failure are all associated with a worse outcome. And next, we're interested in looking at knowing these survival outcomes and predictions of mortality, whether physicians are what their actual predictions of a patient's mortality is following cardiac arrest. And we're able to find 2 small studies that looked at this issue. So this first one is a survey-based study that was conducted in the UK. And what they did was that they took 6 different scenarios, or like clinical cases or vignettes that they presented to physicians at the PGY3 training and above. And they had included a variety of different patient ages, comorbidities, and functional status, and what they were actually admitted for. And then they were able to get responses from 137 physicians, and they asked them whether they would actually recommend resuscitation for this patient case, and if they were to, this patient were to be resuscitated, what they thought would be their estimated chance of survival. And interestingly, there was a couple of cases that were more decisive on whether a physician would recommend resuscitation. So, for example, scenario 6 here was a young male that had a good functional baseline. And was admitted for a STEMI. So as you can see, everyone who responded said they would have recommended resuscitation for that patient. However, there are other ones, like case scenario 4 here, that was more, there was more variety or a variation in what people would recommend. It was about 40% would recommend resuscitation and 40% wouldn't. And you can see that for the estimated survival that physicians would estimate, for those who would not recommend resuscitation, they were obviously had generally lower predicted survival than those who would. But overall, there was quite a bit of variation in what they thought would be their chance of survival and whether they would recommend resuscitation. The next study was a similar study. It is quite a bit older. It was done in 1996, but it looked at something similar. And this was a study done in the US. What they did was they took cases of real patients that underwent cardiac arrest and resuscitation within 2 major US hospitals. And they presented these cases to 51 physicians that were either in family medicine or internal medicine. And they asked them to predict what they thought the estimated immediate survival, so survival to ROSC and ICU transfer, and a bit more long-term, what they thought their survival would be until hospital discharge. And what they found was that physicians were quite accurately able to estimate whether a patient would survive immediately. However, they overestimated whether the patients would be able to survive until hospital discharge, so a bit more long-term. And what they also looked at was another measure of whether physicians would be able to discriminate against patients who would survive in the short and long term. So they compared the physicians' predicted survival between patients who survived and did not survive long term. or survive short and long term. And they found that these numbers were very similar. So they were at a difficult time actually discriminating who would survive and who wouldn't. So overall, given this information, I guess brings the question is, are we able to accurately predict which patients would survive resuscitation? I think overall, it's hard to say. This is a very challenging topic to actually study in reality. These are obviously two very small studies out there in the literature that included a small number of physicians. One was quite old. You can argue that these physicians weren't given enough information that would allow them to actually predict whether this patient would survive in that case, or whether they would do something differently on a survey versus in real life. But I think it shows that there are some cases out there where there's a lot of gray area, and it's not necessarily very easy to predict whether a patient would survive a resuscitative measure.
So, armed with all that knowledge, thank you, Sabrina. What should you do if you're facing a similar conflict? And perhaps a lot of us have gone through similar situations before, but it's always good to review, sort of the steps that we should be taking to protect our patients, protect their families, and protect ourselves in these often sensitive situations. Number one, unsaid on this slide is obviously, maintain great communication with the family, with their SDMs, and with all stakeholders involved. Looking back at the case, at the 2019 case that we initially discussed, I feel that one of the big reasons why this came to a medical malpractice suit, and this is born in the literature as well, is that the communication was, I think, a little bit less than optimal, not at any individual faults, but due to systemic factors as well. And so that's always very important, and sort of frames the whole discussion here. It's very important to familiarize yourself with CPSO policy. So hopefully you have a little bit more information of that today, and of the recent changes and the context that these changes have occurred in, as well as your local hospital policy. Currently, at the present moment, the Hamilton Health Sciences and St. Joe's policies exclude the right to write a no CPR order in the chart, but include your clinical decision making to determine whether CPR is indicated or not. There's some discussion in the chat, and certainly we are aware of updates coming to Hamilton Health Sciences policies that are going to be put forward to the committee this November, so that may change just in a few months or so. Ask for help. And, as an individual physician, it's sometimes challenging to make a very strong determination and present that to patients and their families. So always feel free to reach out to your local critical care physicians, either one or two of them, who are your colleagues who have good experience in this domain and can make recommendations about estimates of mortality, a successful recovery in the context of that individual patient, considering, once again, the potential bioethics concerns of, beneficence and non-maleficence in that role. Communication is always helped by our allied health, so social work and our colleagues here can help mediate any conflicts. And lastly, if this doesn't work, then your ethics committee or ethics consultation is always happy to provide a lending hand. While this process is underway, it's important to recognize that we should always continue to provide medically indicated standard of care during this process. Whether that includes CPR or not is the same as whether it includes antibiotics or not, or fluids or not, at least in the current legal climate. But you have to consider the individual patient and SDM values and your personal risk tolerance for conflict and potential action. So next slide. Brings us to our conclusions for our talk today, and we've tried to summarize it in 3 points. Number one, in the correct circumstance, withholding resuscitation can be as professionally, legally, and ethically justified as providing resuscitation, but it's important to figure out what that correct circumstance is. Number two, survival following resuscitation is poor on a population basis, with a lot of variability between different populations, but it's exceedingly important to try to properly select patients that might benefit from resuscitation in order to optimize favorable functional and neurologic outcomes. Number 3, we should always continue to have early ongoing goals of care conversations, advanced care planning with patients and their SDMs, and provide recommendations tailored to their individual circumstances using our knowledge, our best knowledge of the evidence available. And we would welcome any questions or comments from the crowd.
That's great. Thanks for that, Dr. Gopinathibirla and Dr. Yeung. Great presentation. Got into a lot of the nuances of this challenging topics and how there are many different viewpoints. And thanks for mentioning the CPSO policy. And I think in the chat, Dr. Fox-Robichaud also mentioned that it's currently undergoing revision and will be presented at our MAC soon, which is good for everyone to know. Feel free, everyone, to post your questions in the question and answer. We have Dr. Tang with our first question, who's asking, do we have survival data for patients in the ICU who undergo intra-hospital cardiac arrest? So I don't know if you guys saw that at all. Any good papers on that?
There is definitely papers on that. They're included in the actual systematic reviews that we went through. I don't know off the top of my head exactly what the numbers would be because we mainly looked at aggregate data, but there are definitely papers out there.
Okay. Next, we have Dr. Gerstein has a question. I think he'll want to unmute himself. I'll click answer live.
Great. Can you hear me? Okay.
Yep.
Okay.
We can hear you.
Yeah. Thanks very much for a really excellent, in my view, and nuanced presentation. That's really important. It's more of a comment, and I think this is in my view, it's a very important one. In the list of considerations, one of them was justice, in which one talked about, there was discussion about the societal impact, etc. I think it's really important to stress that that we wear different hats as doctors. And when we are clinicians, societal impact should have zero role in any decision about what we do. The cost is irrelevant. The impact on society, all that stuff should mean nothing to us as clinicians when we're dealing with the patient. When we're a policymaker or when we're a hospital administrator, that's a different issue altogether. But I think it's really important to stress that clinical decision-making should have nothing to do with our judgment of what societal's impact is or the cost or any of those other issues. And I wonder if anybody wants to comment on that.
No, absolutely. I think we agree that on an individual basis, when you're making decisions around the care of a single individual, that the concept of justice does have its limitations. And I think that's the reason why that it wasn't discussed in the court cases at all that led to the decision that withholding CPR is justifiable under the eyes of the law.
Thank you.
Well, thanks for that, Dr. Gerstein. We have one more Q&A question about good websites and information to help people make end-of-life decisions. So I'll let you guys answer that live.
The website I found that was good for families and also care providers is Hospice Palliative Care Ontario. They actually have like modules and worksheets that patients and care providers can go through in having those discussions. Let me see if maybe I can post it here. I'll post it, everyone. Okay. I just posted a link in the chat.
I also use the serious illness conversation guides that are available through Ariadne Labs. I don't have the website on me, but it's ARIADNE. And I find that they're quite good. They provide a whole guide to have that discussion and good questions for physicians also to ask patients. I believe that Dr. Fox-Robichaud has like to make a response to Dr. Gerstein, so I'll let her go ahead with that.
Thanks, Herzl. I think the fiduciary things are sort of the The question that we never ask, but sometimes when we're faced with this in the ICU, it raises its ugly head. We have a couple of cases right now where it's clear that patients, families are not acting in the best interest of the Substitute Decision Maker Act, may in fact be bullying, and may have fiduciary reasons for wanting their loved one to be maintained on life support. And so I think it's it is that elephant in the room that we don't often ask. I think it requires A, more ongoing study, but B, sort of an ethical discussion about why we do not get into the fiduciary reasons, because it may not be to the patient's benefit for why the SDMs are making these decisions. The second comment is the one that I use is I often use, there's a patient decision aid on CPR that was created by colleagues in BC. If you just Google patient decision aid CPR, it actually has, it's probably almost a decade old now, but it actually has a really good tool for explaining to families about end of life and what CPR actually means and its potential benefits. So at one point in the trials group, we were also trying to create an additional one. So I think those are the things. The other thing that I would just, if you're having conflict, you're uncertain about this, what we have been doing while we're waiting for the HHS policy to align with the CPSO policy is we usually get a 2 intensivist consultant, two opinions on the chart and 2 discussions with the family actually probably help more than anything else. And with that, I'll stop because I have to present at the RT conference right now.
Thank you. Thanks for that. And yes, we have been using that. And again, if you're struggling with this, I'd also recommend getting ethics involved. It's becoming quite a challenging discussion, and social work and 2 intensivists combined have not been able to solve the issue. And also, if you're also worried about your own position in the medical legal framework, I'd also recommend getting in touch with the CMPA. They'll advise you on what risk you're exposing yourself to as well. Just a little Q&A. We've got Ukar is saying that I think having maybe a code status put in the health card may help make it a bit easier for people, and this could be reviewed each time it's renewed or in between. Yeah, I mean that's a possibility, kind of like transplants. The only issue is I wonder how nuanced that discussion would be if you're having it in an automated place. And then for goals of care discussion, so that was answered. Dr. Minometri's rounds from earlier this year is available on the McMaster Department of Medicine YouTube channel. So I guess that's someone offering a suggestion if you want to have a more in-depth discussion on see what goals of care, how it's done well. Dr. Minometri, I believe, is our program director for our palliative care fellowship. So he can definitely help out with it. Watching his rounds can definitely help out with that. CMPA and Dr. Doris Samuel also has a question.
Can you hear?
Yeah, we can hear you.
Okay, thank you. So thank you. I'd like to thank the speakers for their very nice presentation. One of the things that I'd like to mention, which I don't think is always addressed, we frequently speak about quality of life in our discussions with patients and or their families. But one of the things that I think is extremely important is quality of dying. In other words, is how they're going to die. And in most cases, it's the impact of suffering. And I think this was very clearly borne out in a study probably about 2 decades ago called the Support Study, published in JAMA in 2 sort of two different studies. And this study was really the precedent of how we now practice at end of life. So I think, one of the things that we should always consider, because many times we talk about quality of life, we already know that the patients have a dismal quality of life given their age, frailty, and comorbid illnesses. So I think one of the things that I would frequently recommend is to talk about quality of dying. Thank you.
Absolutely. I think that's a great point. And something that we didn't manage to talk about today, but something that should be on all of our minds, particularly in the medicine and critical care space. Early involvement of palliative care, if necessary. Early involvement of palliative care principles, such as pain and suffering and quality of dying. These things should be addressed up front, and in some cases can actually improve outcomes.
Yeah, great point, great response, Dr. Ho. I think Allison mentioned it as well, and you mentioned in your presentation as well, but we also want to emphasize that the fiduciary duty of the physician extends to the patient, but may not necessarily extend to the substitute decision maker in the same way. And that role is limited also by the substitute decision maker role is also limited by best interests and also aligning with the prior express capable wishes of the patient. There's some questions in the chat. Documentation of COSTAS is a great help to us. So documentation of COSTAS and goals of care is a great help to us who work in the emergency department, who don't have the same longitudinal relationship with patients. And Dr. Holbrook's asking, is there any other intervention that we know is likely to be much more harmful than beneficial for some of our patients, but we feel forced to offer as opposed to withhold? I don't know if you guys are here with anything else. I mean, top of mind to myself, I think about feeding tube in end-stage dementia is another one. Artificial feeding tubes. And those discussions often become quite similar to our goals of care and withholding CPR type discussions. It'd be challenging to navigate.
I was going to mention feeding tubes and end-stage dementia as well. But one thing, I don't know the data about this, but offering dialysis or renal replacement therapies in very moribund patients probably will not sort of improve the outcomes that we want to improve. And certainly sometimes these things are started in the ICU when patients are incapable of making decisions, and then we're tasked with the decision, how do we take that away, or should we take that away at all? So it's a difficult area.
Yeah, I think in the chat as well, Dr. Tang mentioned Dr. Deb Cook's 3 Wishes project on like the quality of helping patients at the end of life. So I think that's a great project. It's good that it's scaling up. We got 1 more minute. That was an excellent discussion. Great presentation. I think you covered a lot of important material, and you can tell by the discussion that this is a very important topic to everyone, physicians and patients alike. So thanks, everyone. Thanks for presenting, and thanks, everyone, for participating in the discussion.